This is the last video on the concept of diabetic ketoacidosis. We previously talked about the main stars and co-stars in insulin therapy as well as fluid and electrolyte management. And this here is going to be about the supporting cast. So we know that blood gas analysis is critical in DKA as it would help to diagnose DKA and is crucial, usually in the form of VBGs, in the monitoring of patients with diabetic ketoacidosis. Naturally, then, somebody might ask if there's anything that we can do to rectify the acidosis, and the answer is that the kidney should be a best friend. In DKA, proper fluid management and functional kidneys, they tend to resolve the acidosis on its own. Sometimes, however, a patient might be extremely acidotic, and in an effort to resolve this, we could give an alkalinizing agent like bicarb intravenously. But the criteria for this is if the pH is less than 6.9, and in some circles they would administer if it's anything below 7. But the consensus is that there's not much benefit otherwise for bicarb. And the next thing to note about blood gas in DKA is the possibility of worsening of the pH due to large infusions of normal saline. And again, ABG interpretations and anion gaps, they were discussed in previous videos, so they wouldn't be repeated here, unfortunately. And the other supporting management therapy in DKA is prophylaxis against venous thromboembolisms. And typical anticoagulation is low molecular weight heparin, and it's dosed obviously based according to the patient's weight. And this becomes part of management because the condition itself, diabetic ketoacidosis, it can put the patient at risk for increased risk for clot formation. And so we know that the DKA patient would be expected to have some acute on chronic hyperglycemia, dehydration, and decreased mobility. And all of these tend to agree or satisfy most elements of Virchow's triad of abnormal blood vessel wall integrity, stasis, and hypercoagulability. All right. This here is just some about everything else other than what we mentioned in management, and some things that we need to emphasize. So that is, of course, we need to also treat the precipitant of DKA. Otherwise, they just feed into each other and could cause a never-ending cycle. And I mean, just imagine trying to treat DKA in a patient with an unaddressed underlying septic cause per se. All right, and this doesn't sound well at all. And the next thing is we really, really, really need to monitor these patients. We need to be ahead of everything. And I said it before, you don't want to play catch up in DKA. When it comes to the core staple therapies, especially like insulin, fluids, and electrolytes, they need to be monitored frequently until resolution, as well as the patient's clinical state needs constant monitoring. So you want to monitor for insulin effect, right, by looking at ketones, pH, bicarb, anion gap, if there's hypoglycemia and if there's hypokalemia, because we know this insulin is being infused primarily to stop lipolysis and ketosis, and only secondarily for the hyperglycemia. And on that topic, you want to avoid hypoglycemia, because remember, the whole point of cells producing their counter-regulatory hormones like cortisol and glucagon, which cause lipolysis and ketosis, was because these cells thought that they were being starved of glucose, when in fact it was insulin that was the problem. So if we somehow create a situation where glucose is actually deficient, then these cells will just spiral back into ketosis. And well, that was the point of adding dextrose 5% if the glucose goes low, so that you could try to mitigate this. And in the same kind of situation with insulin, if the cells they don't have glucose, they're gonna cry and say starvation. And if the cells they don't have insulin, they're gonna cry and say starvation. So we need to remember to keep the insulin on. And when we decide to convert from IV insulin to subcutaneous insulin, we need to make sure that there's an adequate overlap. So we can't turn off the IV insulin as soon as we give the subcut injection, because we need to allow time for the subcutaneous injection to get into circulation, and it needs to peak. And all of that takes time. And in that time, patients can slip back into ketosis. So keep the IV insulin on running for about 2 to 3 hours after we give the subcutaneous dose to try to prevent that relapse. And throughout management, you need to keep your endocrinologist involved. Don't be afraid to call ICU or HDU if need be. Throughout management as well, all eyes needs to be open for the possibility of complications. And out through this entire series, I was constantly mentioning cerebral edema. It is more likely to occur in the young. Things like headaches, altered mental status, irritability, all these could be early signs of cerebral edema. And a clinical exam could indicate Cushing's reflex, pupillary changes, all of that, incontinence and all of that. And these patients are treated with mannitol 20%, and you're giving about 0.5 to 1 gram per kg over 10 to 15 minutes. Or you could use hypertonic saline 3%, about 2.5 to 3 milliliters per kg over 10 to 15 minutes. Other complications could include arrhythmias, and this could be likely stemming from potassium derangement. And then you have DVTs that we previously discussed. You have ARDS, and this would certainly need a ICU or HDU involvement. And if we could recall the list of parameters that we defined severe DKA in the investigations video, and we mentioned that in these severe cases, we need ICU HDU involvement. And so that's why the low PO2 was there, to try to cover for this ARDS complication. And then lastly, we have the acute kidney injury as another complication of DKA. This finally brings us to the end of the DKA concept. And I do hope that it brought some benefit. And if there was anything that I left out or any mistakes throughout the videos, you feel free to let me know in the comments. But until next time, bye-bye.